You are listening to Plastic Surgery Uncensored with Dr. Roddy Raban on Revolver Podcast.
On this episode of Plastic Surgery Uncensored, I have my dear friend and colleague, Michael Houston, who's my anesthesiologist, who's my co-pilot in surgery. She's going to be helping us elucidate some of the concerns and fears which patients consistently tell me about during surgery. And you want to tune in. You want to hear what she has to say. It's going to be a really exciting episode. Welcome to another episode of Plastic Surgery Uncensored. It's your host, Dr. Roddy Raban. And today's topic is probably one of the most important topics we've ever had on Plastic Surgery Uncensored. And that says a lot because we've talked about a lot of important things. It's about anesthesia. As anyone who has had surgery knows, the anesthesiologist is truly the co-pilot during surgery. So that means that you could spend months and months researching your surgeon, but if your anesthesiologist, whom you almost never research, is not a good one, you could have a terrible, terrible outcome. I am so blessed that the team that I work with is made up of some excellent people, the co-pilot of which is Dr. Michael Houston, who's joining us today. She's really honored us by being here. And we're going to really kind of make a serious dive into everything anesthesia related, whether that be the fears, the importance of certain training. We're going to talk about what a good anesthetic experience is like, nausea, vomiting, everything you can imagine. So you definitely want to tune in and hear what she has to say. So, Michael, welcome.
Hi.
How you doing?
Everybody, thanks for having me.
All right, so this is a different experience for you and me. Usually I'm on the other side of the blue tarp, and you're on the other side running the show while I'm doing my thing. We're so happy to have you, and thank you. You and I talked about this for a long time because it's funny, so many of the questions I get, I mean, obviously the questions you get are going to be about anesthesia. You're the anesthesiologist. You can't imagine how many questions I get during my consultations, appropriately, about anesthesia, about the fear, about all those things. And then, you know, I usually tell them, oh, don't worry, my anesthesiologist is amazing. She's extraordinary. She'll take great care of you. But the reality is that people often don't get a lot of information about anesthesia. I mean, if you go out there right now and you're like, I want to have a mommy makeover or tummy tuck, you know everything there is to know about tummy tucks, you know about aftercare, you know about everything, but there's zero information about anesthesia. Yet it's, I mean, dare I say, one of, if not the most important part of your surgical experience. So let's start with, I think, the most important thing. I mean, we drive right in. People don't look at anesthesia as a fun experience. People don't look at anesthesia as it's going to be okay. It always starts with fear, right? Fear, fear, fear. So let's go over the fears, because there's a lot of them that relate to anesthesia. And then I'm going to ask you your input and how, is it real? Is it not real? How do you address it? Whatever. So the first fear is death.
Right.
Like I hear people like, Dr. Bond, do anything, but just make, I have 3 kids, just make sure that I wake up.
Right.
So what do you say to patients when they talk about death?
I let them know that first and foremost, we do everything to make sure it's really safe. We've never had a death.
Right.
We don't anticipate a death. They're very healthy or healthy enough, and everything has been optimized, or they wouldn't even be there that day. I know what I'm doing. And let's say it's someone else out there who's going to, going for another surgery or with another anesthesiologist. Most people have good training. The chances of dying are really rare if your anesthesiologist is paying attention and watching everything as it's going, watching the surgery, and knows what to anticipate. So in the cases that we do at the surgery center, we do the same cases. We all know the routine. We all know that the patients have been cleared medically.
Right.
If they need a special medical consult from their regular doctor or an outside doctor, we make sure we have that. We make sure we review all of their labs, and we go over the whole plan with them.
So what you're saying over and over again is we're prepared. So first and foremost, let's just address the raw numbers. Death during anesthesia
Extremely
is
rare.
incredibly rare and unlikely. Okay? You're not in Guatemala having this done in some back alley clinic.
Right.
We're talking about people who go to legit doctors in legit facilities with legit anesthesiologists. You may have a bad anesthetic experience.
Right.
You may wake up nausea and vomiting and in pain and with a sore throat.
Hopefully not.
No,
But-
we're not talking about it with us. We're talking about generally, because I'm
Right.
addressing these fears not necessarily as it applies to us and people coming to us. We're talking about people across the board. You're a mom living in Minnesota, and your daughter's about to have a breast augmentation. There's going to be fears there. So in general, just raw numbers, death, I always like to say that you're more likely to get in a car accident on the way to and or from your surgery than you are to die. So
Yes.
that goes across. And the reason that is because of everything that Michael was saying, which is, I mean, again, all these are assumptions. The assumption is that you go to a safe doctor and a well-trained doctor with a well-trained anesthesia, et cetera. So,
and if you've told Dr. Raban or told his staff or told someone at the surgery center or told myself or whoever your doctors may be, told them all of your health history as far as you know it.
right.
When you can run into problems, which we haven't, but when it's more of a chance that it could happen is if someone has like withheld information.
Right. So if you have a cardiac condition, if you have a pulmonary condition, you don't want to withhold that information. When would that happen? This is the scenario. Patient really, really wants a surgery. Mm-hmm. They know that if they tell the doctor that they had 2 stents put in, they're probably not going to have it done or canceled. And so they don't tell them that that's the case. And so as a result, God forbid something happens and we're not prepared.
Right.
It's not that if you have a heart condition, you can't have surgery. It's just that we need to make certain preparations.
Exactly.
So another major concern, which you know personally, is nausea and vomiting. I would say that's the second most dreaded fear of a patient, which is actually a real fear.
Right.
So I try to tell patients when they're having surgery, nausea and vomiting can definitely happen, but when I say every step, we take every step. So what are the steps that we take for nausea and vomiting?
So the first step is to talk to the patient and find out if they've had any surgery before, or if they even have experience of car sickness, motion sickness, any prior times in their life where they've had like nausea and vomiting with any of their pregnancies or something like that. So are they someone who's more prone to nausea and vomiting than the average person? Like myself, I'm somebody who's actually more prone to it. Then
Ironic.
I know. Then,
but it makes you a very sensitive anesthesiologist.
Right. Then the next step is, what are they having done today? Are they having a breast aug? That has a little bit lower risk. Are they having a rhinoplasty? Are they having abdominoplasty when afterwards all those stomach muscles and abdominal muscles will be nice and tight and smush the stomach? Then they're more prone to have nausea and vomiting. So we'll put those factors together. Hydration is a big part of it, number one, even more than any medicine. So you're not eating anything right before surgery. So then I'm going to rehydrate you a lot. Then I'm going to give you different medications, and I'll really go into detail if someone's at a high risk on exactly what they should do afterwards. Being sure to eat small meals afterwards, being sure to take all the nausea and vomiting medications afterwards as well. And then we have special medications that we can use for people who have severe nausea and vomiting. There's a patch that can be applied to your skin, and that can help limit or even eliminate those symptoms for 3
scopolamine
days.
patch, right?
Scopolamine
It's
patch.
similar to what people take when they get on a boat.
Exactly.
It's a motion sickness type patch. That's one thing. What else you give? You give them droperidol.
Droperidol if it's available. Droperidol is excellent. Some places don't have droperidol. Reglan, Zofran, and then Decadron is a huge one.
Right, which is a steroid. And then on top of it, you may use more propofol than a gaseous. So the point we're trying to make is that if your anesthesiologist is a well-trained anesthesiologist, and if your anesthesiologist is sensitive to your nausea, there are probably 10 maneuvers you can do to reduce, not eliminate, reduce the probability that you'll have some nausea and or vomiting. So it's really, really important. Okay, I hear, my God, at least once a week, people's fear is starting the IV. I mean, I have patients who literally say to me, I said, well, any questions, any concerns? Yeah. Can I get some like anti-anxiety medication? What do you need it for? The IV.
Right.
So a lot of people are scared of needles, and so their fear is around the IV. What do you do with the IVs? You tend to be super successful with IVs. Suggestions and or what do you do with patients that are scared?
Right. A lot of people are scared because they've had a not so pleasant IV placement before where it was really painful, or it took the person like 5 times to get their IV.
Like their pincushion?
Right.
Right.
And then there are a few people who truly have super tiny, small veins. And there's also another small group of people that just are truly anxious. They are crying from the beginning, even before you step into the room. So for most of the people, I'm able to let them know, I can see your veins. You have good veins. Don't worry. I'll be able to get your IV in one stick. It's not going to be an issue. Even if somebody had a problem before, maybe they just went to
the wrong anesthesiologist.
Or a wrong blood draw or something.
Wrong anesthesiologist.
Anyone who has really small veins, where I'm like, oh yeah, your veins are actually really small. Or anyone who is just literally physically crying and hysterical before I even get in the room, then I say, guess what? Guess what we do for a lot of pediatric patients? We bring you to the room and we have you go all the way to sleep first and then put the IV in. And so I offer that to a small
I want you guys to hear
subset of
that.
people.
That's not like, you guys listen to me week after week talk about sort of the gold standard in plastic surgery. What some people do, they cut corners, they may not go the extra mile for you. What would you do if it was your sister, you were having surgery? There's the same protocol when it comes to anesthesia. There's average anesthesiologists, there's good anesthesiologists, and there's amazing anesthesiologists. And those that are amazing go the extra mile. They do the things that you would want them to do if they were related to you. So the idea or notion that Michael's talking about is to take you into the operating room and put you semi-asleep to the point that you're not fully aware, give you some gaseous anesthesia, which they do for pediatric patients, so your veins dilate, is something that you should be able to ask for if you and your anesthesiologist have a good relationship. Pain, people are afraid of pain. They're always worried they're going to wake up in extreme, excruciating pain. We know that doesn't have to be the case. Mm-hmm. If your anesthesiologist is awesome and paying attention, they can't make your pain go away, but they certainly can make it more tolerable. So what do you do about pain?
In terms of pain, it's multimodal. So we want to use as many things as we can instead of just all opioid pain medications.
Why is that?
Part of that, well, this is even prior to all of the rightful news coverage and rightful concern regarding opioid abuse, but it actually is better to control pain in different modalities,
right?
Just than using one modality.
And the fact of the matter is that if you try to treat all the pain with just narcotics, you're highly likely to be nauseous.
Yeah.
So right, if you rather than just cranking the bass, but rather a little bass, little treble, little whatever other things, you get a better outcome. It's equalized as opposed to a single hammer. So you use different kinds of modalities. That's one thing.
Right, different kinds of modalities. Part of it is coming from your side, which is the local anesthetic.
Right.
So that's
so
great.
Stopping the pain before it starts, that's huge. There's been, 100 studies that show that if you prevent the pain spike or the pain cycle from occurring, it's much easier to control it than if you're already in excruciating pain. So that comes from your physician taking time and injecting local anesthetic before. So the argument is like, what do I need to inject local for? Right? You're asleep. You're not going to feel this. The reason I inject local, aside from the fact that it stops some bleeding, is because it makes your pain later in the case much less.
Much less, exactly. So I like to use more, I would say short to intermediate acting pain medications rather than something that's super short acting or super long acting. Then I get the people to a comfortable level. They wake up, they're comfortable, and then afterwards, if they want to take more pain medication, then they can, according to the prescription. If they're doing great without it, then great.
Which most patients, you would say that most patients, we won't mention, but there's another doctor in the in our facility in the next room, and we can tell when his patients are out of the operating room because in the recovery, when they're not conscious, they're moaning and groaning. They're in a lot of discomfort. We don't have that. Patients are calm, they're comfortable. That's because of a combination approach that we take so that you're not in any excruciating pain. The surgery is uncomfortable, but you don't need to be like out of control pain.
Right.
So there's a lot. I know this is one of your pet peeves, but the idea or the notion of allergies versus reactions. I know you make such a you go nuts over this. Everyone has pet peeves. Patients who come in and say, "Oh no, don't give me epinephrine. I'm allergic to it," which is like you being allergic to oxygen, or I don't take this, that, the other, etc. So, what are your thoughts on allergies or reactions, or actually been badly administered?
Yeah. So I'm not. It is a pet peeve of mine. I just want to clarify. I'm not mad at the person because oftentimes they were just given this information.
No, you're mad at the garbage that's being told to them. Is what I'm saying.
I'm allergic to penicillin. Oh, okay. What is your allergy? I don't know, but my mom told me that I had a reaction when I was a child. I'm like, okay, well, you're probably not allergic. We won't be giving you actual penicillin, but I'll be giving you a different antibiotic, and I'll test first to see if you have a reaction. And I think I mentioned this a few weeks ago. I really don't think I've ever seen anyone personally. I don't think I've ever witnessed anyone personally actually have an allergic reaction to the antibiotics. So I've seen 2 people have an allergic reaction to latex. So, I've definitely seen a number of people. I'm allergic to, quote, I'm allergic to epinephrine. Epinephrine is in our body. So it's like, no, you're not allergic to it.
So the reason why allergies are important isn't because we're bothered by it, because what it does is it restricts us from giving you what is ideal.
Right. And
then we have to give you something that's sort of secondary or in lieu of. And the reality is that what patients understand is when they create, maybe not to any fault of their own, all of these restrictions, I can't have this, I can't have this, I can't have this. The problem is what happens is that they end up having to get something that maybe isn't as good, a different antibiotic, etc. So we're going to take a quick break. Mm-hmm. Then we'll come back and we have a few more questions on this session. We have the luxury of having Dr. Michael Houston for 2 episodes. So you guys better listen in because this is everything you need to know about anesthesia. But when we come back from the break, we're going to talk about the difference between general anesthesia and conscious sedation, because there isn't a day that goes by that people aren't asking me if I can do it awake, twilight, because they think general anesthesia is like the devil. They're never going to come back. So make sure to tune in. We'll be right back with Michael on this great topic.
You are listening to Plastic Surgery Uncensored with Dr. Roddy Raban on Revolver Podcast.
Welcome back to Plastic Surgery Uncensored. I'm here with Michael Houston, my dear friend, and most importantly, my esteemed colleague, co-pilot, and anesthesia extraordinaire. I think this segment is so important as we're kind of traversing all questions anesthesia related. I know in my practice, and I know with any surgeon's practice, they get a ton of questions related to anesthesia. Obviously, it's such a huge part of what we do. And interestingly enough, I don't think there's really much information on anesthesia in general. I mean, you could Google it, I guess, but there isn't a collective group of information talking to anesthesiologists as a patient's perspective. So welcome back. We were just talking about fears. One common fear is this idea of general anesthesia. Mm-hmm. There's general anesthesia has a bad rap. It's like, oh my God, it's general anesthesia. Oh no, it's so major. Can I do it under conscious sedation or twilight? And so we need to talk about that because it gets me flustered and not flustered. It's frustrating because it's not true. And more importantly, a lot of doctors are sort of capitalizing on this fear. And what they do is they market to patients telling them that, oh, I do this under twilight and those other doctors do it under general. And it's so bad for you. And honestly, it's so frustrating because A, that's not true. B, I could argue the reverse, which is conscious sedation, in my opinion, and you can chime in some ways is more dangerous and more risky because anesthesia that's general has more protections in place and actually protects you from mediocre anesthesiologists. And ultimately, you are more comfortable and hence is your anesthesiologist. So with that segue, give me your thoughts on conscious sedation versus general anesthesia and don't be shy.
Right. For the surgeries that people are coming to the surgery center to have. So rhinoplasty, breast augmentation, mommy makeover, full on facelift with, and a breast dog or something, you name it. General anesthesia is going to protect their airway. It's going to be a more secure environment. Oftentimes we're sitting the patient up. Oftentimes the table is turned away. And so that just adds another layer of protection, that their airway is secure.
Can you explain
many? I will.
the difference between conscious sedation and general anesthesia, just out of the cuff? So there's a
Sure. So
what is the difference?
general anesthesia is the person is completely asleep, and most general anesthesia in the United States is with an endotracheal tube, a tube that goes down your throat, or with an LMA, which is a special airway device that goes.
Which
in your
means
mouth.
essentially you have something that helps facilitate your breathing as
Right.
opposed to you breathing on your own, right?
Right. Exactly.
So it's a depth. General anesthesia is the same as conscious anesthesia in that you're deep. General anesthesia, you're deeper, in
Yes.
which case you need assistance in breathing for you. And as such, your airway, that's the part that you use to breathe, has to be protected from you getting fluid or things down it because you can't protect your airway. Is that a good? Okay.
And some general anesthesia, obviously, I have taken completely over their breathing, so they are no longer even
Or they can
breathing
breathe
on
on their own.
That it can be with breathing on your own, or without breathing on your own. Either way, you're completely asleep. If someone's at the point where they're not breathing on their own, they're okay. They're totally fine because I or the anesthesiologist has taken over that for them.
Yeah, you have a ventilator.
Right,
And you do those
ventilator, or I'm doing it manually. But you need to make sure that the airway is protected. So if you have conscious sedation, it's a twilight. So they're supposedly breathing on their own, but if it goes too deep, if something goes wrong with the procedure, depending on what the procedure is, like people go for upper endoscopy, lower endoscopy. If it's for just regular screening, they're going to look, they're going to take a biopsy, everything's going to be fine. If it's for diagnostic, someone happens to come in for bleeding or something, there can be really bad things that happen.
Yeah, and I think what people don't understand, and I really want to make this point, kind of drive it home with you here present, is there's this idea that conscious sedation is safer. It's no more safe, no less safe. It's just another variation. But this idea that general anesthesia is not as safe is wrong.
Depending on where it's being done, if it's being done where someone thinks they're comfortable doing the conscious sedation, but all of a sudden something happens and they're not safe really taking over and doing the general anesthesia, that's when people can run into big problems.
So the thing that you need to understand is that both of them are fine. There are many places where they do conscious sedation incredibly safely. There's a lot of places that do general anesthesia incredibly safe. The point isn't whether or not one is better than the other. The point is, do not assume incorrectly that general anesthesia is less safe and therefore request it or be fooled by marketing that suggests that if you're under conscious sedation, it's going to be less harmful or less this, the other. It's all the same. The only thing that should matter to you, is that your surgeon and your anesthesiologist are able to safely perform surgery anesthesia on you using whatever technique they find. That's like the idea between open and closed rhinoplasty. All you care about is your nose looks good. So if your surgeon knows how to do it open, great. If he does it closed, it's great. The same, 6 of one, half dozen the other. So that I had to harp on. Then we're going to harp on another subject matter of mine, which is anesthesiologists versus CRNAs. So every time I mention this to people, they're like, what? This would be the equivalent of plastic surgeons versus OBGYNs doing tummy tucks. Not exactly, but similar. So bear with me. So when you go and see someone and get a tummy tuck, everyone just assumes that person is a plastic surgeon. They're all the same. And that's not the case. We have plastic surgeons and we have cosmetic surgeons, which we've touched on many times. And a cosmetic surgeon is not a plastic surgeon because their training is different and this, that, the other. Does that mean a plastic surgeon is better than a cosmetic surgeon? It means they are different. They're not the same. That's up to you to figure out. When it comes to anesthesia, we have a similar situation. We have anesthesiologists, doctors who went to medical school, who went to residency, who may have gotten subspecialized. And then we have nurses who go on to get further training in CRNA. What does that stand for?
Certified registered
nurse
anesthesiologist.
Nurse anesthetist. See, you just killed it. So what that means is they're nurses who do anesthesia. Did you hear me? Nurses who do anesthesia. That doesn't mean they're bad. It just means they're different. They have a different training. They have a different skill set. They didn't go to medical school. They didn't go to residency. Often CRNAs, not always, are under the supervision of an anesthesiologist in a hospital. Now, there are some CRNAs that are amazing. I've worked with them in foreign countries, on pediatric patients, in little operating rooms with flickering lights. So I am not by any means saying one is better than the other. I'm just telling you that you need to be aware. Like most things, if you were to extrapolate and make a generalization, which is a dangerous thing to do, people who are anesthesiologists have better training. They have more of it. And so in general, and there's a reason why I only use anesthesiologists, AKA Dr. Houston, the world's greatest. But it's because I feel more comfortable for my patients. Now, CRNAs tend to be a little more affordable. You see that? So you go to a doctor and you say, oh my God, my doctor is like, he's doing my breast talk for $5,000. Your doctor, how much? $7,000? Oh, hell no. Well, let me just tell you something. That $2,000 was Dr. Houston's paycheck. So you have to understand, you don't get nothing for free. So when you go to someone and you pay less, you get less. And one of the things you don't get is you don't get a board certified, amazing anesthesiologist. One of the things you don't get is a kick-ass operating room. One of the things you don't get is amazing anesthesia equipment. You just don't. You don't pay $5,000 and get a Lamborghini. It just doesn't work that way. So I'm not saying that you can't have an amazing outcome with an CRNA. I'm just trying to make sure that people are knowledgeable because a lot of things just kind of just go under the carpet. So that's that. And the last topic before we end this segment is board certified versus board eligible versus reality is basically not board certified. So for all intents and purposes, we want to touch on this last space before we end this segment in order to start the next segment, which I hope people tune into because it's super enticing, is like we talk about on our end, there's board certified surgeons, and plastic surgery and whatnot. So tell me about board certification, not board certification, eligibility. What's all that about in anesthesia?
Board certification. So once a doctor completes their entire anesthesiology residency, they take the steps of board for certification. They take exams while they're in residency. They have to successfully complete and pass those exams. Then they're eligible to take the written board certification, and then they're eligible to take the oral board certification. And only after they complete all of those things do they become board certified anesthesiologists.
So really easy stuff, just like a weekend thing.
It's like a weekend course.
Yeah.
No.
Why the hell would you do that as a doctor? Why get it? It's just a headache. Why just not be not certified? Patients don't know the difference. They don't seem to care.
There are certain places where it's highly desirable or almost mandatory to have it, but there's many places where it's not mandatory to have it, but it just shows that you have completed all the steps and you have a higher level of knowledge. You're able to be an in the operating room consultant, and so it just increases your
what it basically says is it gives you more credibility. Again and again and again, we're just going to keep hitting the same topics. There are no guarantees in life. You can go to the best surgeon in the best facility with the best anesthesiologist and have a terrible outcome. But at the same time, if you go to Guatemala, nothing wrong with Guatemala, I love it, and you end up having some dentist do your surgery by some random person, the probability of having a bad outcome statistically is 1,000-fold higher than the other scenario. So if you can, you should choose to be with a board-certified anesthesiologist. If you can, you should choose to be with a board-certified plastic surgeon. If you can, you should be in a Medicare-certified facility. Why? Because these things just ratchet up your probability of having a good outcome. Doesn't say that you couldn't, but it's just ideal. So, I mean, those are some serious topics we talked about.
Yes.
I think people are start to getting their feet wet. Well, it was amazing having you on this episode. We will do a second episode where we're going to touch on a few bunch of other things that I think like patients need to understand about their experience, the day, how you make. Why am I getting constantly patients saying, oh my God, your anesthesiologist was amazing? I mean, there's a reason for that. You have your way of doing things that we want people to know what that is so they can not necessarily come here, obviously, but expect that when they go elsewhere. Mm-hmm. So thank you for tuning in to another episode of Plastic Surgery Uncensored. It's Dr. Roddy Raban with Dr. Michael Houston. I hope you tune into another episode. Make sure you share, subscribe, and download, and tell all your friends.
We would love to get your feedback. If you enjoyed and found our podcast helpful, Tell us why. Give us the review and subscribe on your favorite podcast platform. We can be found on Apple Podcasts, Google Podcasts, Spotify, iHeart, or you can go directly to revolverpodcast.com. If you have a topic you would like us to talk about, then please reach out to us on Facebook, Roddy Raban, Instagram at Dr. Roddy Raban, or roddyraban.com. You are listening to Plastic Surgery Uncensored with Dr. Roddy Raban on Revolver Podcast.